federally qualified health centers that serve some of our most vulnerable neighbors, and other specialized health care facilities such as the Ryan White HIV/AIDS clinics also benefit greatly from 340B. Now, critics will point to the growth of 340B as evidence that it is not working as intended. But just because a program has grown is not evidence that it's not working. Increases in the cost of drugs, especially specialty drugs, is one reason the program has grown. And it's a reason why the drug discounts are more important than ever. The growth in 340B drug discounts still only amounts to a small percentage of drug companies' enormous revenues. But we know that drug companies do not like any chipping away at their massive profits, and they have fought 340B drug discounts for years. Major pharmaceutical companies rake in tens of billions of dollars in revenue every single year, and drug prices for consumers continue to go up, up, up. While 1 in 4 Americans struggle to pay for their prescriptions, each of the 15 highest paid pharma CEOs made over $15 million in base salary, bonuses, and stock options in 2021. Drug companies spend large sums on advertising and marketing in the U.S. Meanwhile, Americans spend double what patients in other countries spend on their medications. Even with the 340B discounts of about 25 to 50%, Americans likely pay more than what typical patients in other countries pay. Back home in Florida, the 340B drug discounts provide important resources to hospitals and clinics as they take the savings to fill gaps in care. For example, one of the largest health systems is Baycare, uses 340B savings to fund their medication assistance program where patients in need can receive reduced cost medicine. 80% of patients enrolled completed outpatient infusion treatments that they otherwise could not afford. Baycare is also able to operate a kids' mobile medical clinic that has provided over 2,000 immunizations and other screenings for children from working-class families. At Tampa General Hospital, they operate a clinic that primarily supports working-class patients, and is one of the only places that these patients can get appointments with specialists. That clinic operates at a net loss of millions of dollars that are made up for, in part, by savings from 340B. Tampa Family Health Centers uses its savings to ensure young adults struggling with mental wellness can access necessary behavioral health treatments. Avera Health in St. Pete has used its savings to provide dental care, case management, and health coaches, leading to better health outcomes and more comprehensive care for patients. These are just a few of the examples in my district how we all benefit from 340B discounts. Without the savings provided from 340B, all of this kind of expanded care would be at serious risk. And this is true all across the country, including in this subcommittee. Nearly every member of this subcommittee has at least one 340B registered center in their district. Most have 3 or more. So when we talk about oversight and potential reforms, I want to be sure that we're very clear about the benefits of the 340B drug discounts for our neighbors and what the consequences would be if Congress acts to significantly restrict these discounts. So I appreciate your sentiment of keeping patients at the heart of the discussion today. I urge us to do that as well. Thank you, and I yield back.
Gentlelady yields back. Now recognize the chair of the full committee, Ms. Rogers of Washington.
Thank you. Good morning. Thank you, Chairman Griffith. This hearing is an opportunity for us to evaluate recent trends and developments in the healthcare system that impact the 340B drug discount program. The 340B program was created by Congress to, quote, enable covered entities to stretch scarce federal resources to reach more eligible patients and provide more comprehensive services. It's a worthy goal and a seemingly straightforward one. For community health centers, high disproportionate share hospitals, and rural providers, savings from the 340B program are critical. In some cases, savings from the 340B program are helping keep the lights on at what may be the only hospital in a rural community. And those cases reflect the spirit and intent of the law to ensure essential services for our most vulnerable communities. With that said, I worry that the program is being co-opted by larger, more profitable healthcare systems that are using it solely for financial gain at the expense of the patients that need it most. We've talked a lot in this committee about addressing the impacts that high healthcare costs have on patients, employers, and taxpayers, and how we need to work to create a simpler and more transparent healthcare system. Every single one of us pays for the high cost of healthcare, whether that's at the doctor's office, through our insurance premiums, or in taxes that cover the ever-increasing cost of Medicare and Medicaid. Something that's becoming increasingly clear is that the 340B program is distorting markets and behaviors in our healthcare systems that are creating cost for all of us. In multiple studies, researchers found that the 340B program was associated with a nearly 25% reduction in the prescribing biosimilars and other lower-cost drugs in favor of more expensive brand name alternatives, so that hospitals could pursue larger savings from the program, even though patients' out-of-pocket costs are not tied to any of the savings that the hospital may receive. Additionally, the New York Journal of Medicine found that the program further incentivizes hospital systems to acquire independent oncology practices so that they can expand their 340B footprint. Some will argue that hospitals reinvest these savings in ways consistent with the intent of the program. But there's little evidence to prove this. This committee has focused so much effort over the past 2 years on increasing transparency in healthcare, tackling incentives in the prescription drug market that push up healthcare costs for Americans, and addressing site neutrality and other reforms that are driving consolidation. It should be a bipartisan goal for every member on this committee to apply the same principles to the 340B program as well. Let me reaffirm once more that I support this program in its original intent and mission. Last year we heard from Pullman Regional Hospital in my district about the value that the 340B program provides to them and other hospitals. I visited them in Eastern Washington and across this country. We've also heard testimony in support of increased transparency for the program so that we can, at the very least, understand how covered entities are using this program. If we are serious about lowering healthcare costs for Americans, then we must take a critical look at the 340B program and make sure that it is achieving its intended mission. So I look forward to hearing from the witnesses today, and I yield back.
Gentlelady yields back and now recognize the ranking member of the full committee, Mr. Pallone, for his 5-minute opening statement.
Thank you, Mr. Chairman. The 340B drug pricing program is incredibly important to the ability of hospitals, community health centers, and specialized clinics to provide comprehensive quality health care to underserved populations across the country. For more than 30 years, 340B eligible providers have depended on the savings the program provides them to remain open, provide more care to more patients who need it, and expand the services that they provide. Drug manufacturers are required to sell discounted prescription drugs to providers that meet the 340B statutory eligibility requirements, and this allows these providers to stretch scarce federal resources to reach more eligible patients or provide more comprehensive services. And without these discounts, some providers with the slimmest fiscal margins would be forced to significantly pare back the care they provide, or even worse, close their doors altogether. And 340B plays a critical role in preserving healthcare access, particularly in underserved areas. Now, President Biden and congressional Democrats have championed landmark legislation that's already lowering healthcare costs, including prescription drug costs for Americans. Unfortunately, we've not found willing partners on the other side of the aisle. Every Republican in Congress voted against the Inflation Reduction Act, which empowers Medicare to negotiate prescription drug prices and caps the yearly out-of-pocket drug costs for seniors. And thanks to the Inflation Reduction Act, the Biden administration is in the process of negotiating lower drug prices for the first 10 drugs selected for negotiation. These drugs are taken by about 9 million seniors and collectively cost them out of their own pockets $3.4 billion in 2022. Medicare also spent more than $50 billion on these 10 drugs that same year. This law is making prescription drugs more affordable for American seniors, and Democrats are working every day to protect and expand on these money-saving advancements. But this subcommittee has held oversight hearings on 340B in the past, and I appreciate the continued attention to this vital program to make sure it's being effectively administered. We do need to ensure that covered entities are using the savings from the 340B program appropriately and that low-income patients are receiving the full benefits of these savings. But that being said, I am concerned that this hearing will not allow for a balanced discussion about 340B in its future. I'm not sure that we have all the right witnesses here to give a complete perspective on how the program is working. For example, the Republicans did not invite a single drug manufacturer here to talk about their part of the program. We will also not hear from the Health Resources and Services Administration, HRSA, about what the agency needs to oversee the program. And furthermore, the significant reworking of the 340B program that some of our Republican colleagues recently proposed will not reduce prescription drug costs or expand access to care. Restricting 340B does not save taxpayer money or lower health care costs for patients. In fact, undermining 340B would severely weaken the health care safety net, create greater obstacles for people who already struggle to receive accessible, affordable care. When 340B eligible providers can save money on prescription drug purchases, it helps them provide better services that are responsive to the needs of their communities. They report a variety of benefits from the program that allow them to strengthen their institutions, improve quality and affordability of care, or reach a larger patient population. So I hope we can have a real conversation today about the importance of the 340B program for the safety net providers that communities depend on and how Congress can maximize the benefits it is already delivering to communities across the country. And with that, Mr. Chairman, I yield back the balance of my time.
Gentleman yields back. That concludes member opening statements. The chair reminds members that pursuant to the committee rules, all members' written opening statements will be made a part of the record, and please provide those opening statements to the clerk promptly. We want to thank our witnesses for being here today and taking the time to testify before the subcommittee. You will have an opportunity to give an opening statement followed by a round of questions from members. The next step would be for me to introduce you all and get you sworn in, but we're going to break for votes at this time and recess. I apologize again to you all and to the folks in the audience who are watching us, but sometimes you got to do what we get paid to vote, so we're going to vote. And we'll go take care of that. We will start, so that members understand, we will start as soon as Ms. Castor and I can get back here because we are going to the next phase. So we will go from there, and hopefully we won't be gone too long. Thank you all for your patience. With that, the subcommittee is recessed.
No 10-minute warnings. Get back here.
Subcommittee will come to order. I'm now going to recognize Representative Duncan of the 3rd District of South Carolina. It's a little bit out of order to introduce Ms. Veer. We're going out of order because he is chairing another subcommittee downstairs. So, Representative Duncan.
Thank you, Mr. Chairman and the ranking member, for the opportunity to introduce a constituent of the 3rd District of South Carolina, Ms. Sue Veer, who I can barely see behind Diana there. But Sue is president and CEO of the Carolina Health Center based in Greenwood, South Carolina. Sue and her great team provide care for 7 rural counties in the 3rd District of South Carolina. She's a champion for rural health, and I look forward to hearing her testimony today. One thing I'm most proud of is she helped create a community care center in my hometown of Lawrence, where we put it in an old emergency room adjacent to the existing emergency room to create an opportunity for folks to have a health home instead of seeking higher cost medical care at the emergency department, to go to the LC4 is what we call it there. Sue, welcome to the committee. I look forward to coming back and asking questions later, and thank you, Mr. Chairman. I yield back.
Thank you, and gentleman yields back. And now recognize the remainder of our witnesses for today. Dr. Anthony DiGiorgio, neurosurgeon, University of California, San Francisco Health. Dr. William Bill Smith, senior fellow and director of Pioneer Life Sciences Initiative, Pioneer Institute. And Mr. Matthew Perry, president and CEO of Genesis Healthcare System. We appreciate you all being here today, and we all look forward to hearing from you. As you are aware, this subcommittee is holding an oversight hearing, and when we do so, we have the practice of taking testimony under oath. Do any of our witnesses have an objection to taking testimony under oath today? Seeing no objection, we'll proceed. Further, the chair advises you are entitled to be advised by counsel pursuant to House rules. Do you desire to be advised by counsel during your testimony today? Seeing none, if each of you would rise if you can and raise your right hand. Do you promise and affirm to tell the truth, the whole truth, and nothing but the truth, so help you God? Seeing the witnesses have, you all may be seated. Seeing the witnesses have answered in the affirmative, you are now sworn in and under oath, subject to the penalty set forth in Title 18, Section 1001 of the United States Code. With that, we will now recognize Dr. DiGiorgio for 5 minutes to give his opening statement.
Thank you. Chairman Griffin, Ranking Member Castor, I'm Anthony DiGiorgio. I'm an assistant professor of neurological surgery and faculty member at the Institute for Health Policy Studies at the University of California in San Francisco. I work as a practicing neurosurgeon primarily at Zuckerberg San Francisco General Hospital and Trauma Center, our county-run safety net hospital. I'm honored to testify before the committee today on 340B, and thank you for putting together this hearing. My testimony reflects my personal views and does not necessarily represent those of UCSF, its Department of Neurological Surgery or Institute for Health Policy Studies, San Francisco General Hospital, or the Mercatus Center. Today, speaking as a frontline clinician in a safety net hospital, I'll focus on the abuses of the 340B program and potential areas for reform. The 340B drug pricing program was intended to benefit hospitals like mine by providing discounted medications to covered entities, or CEs, allowing them to stretch scarce resources to help underserved communities. However, over the years, the program has grown to include thousands of hospitals, many of which are not fulfilling the program's original intent. These large, consolidated corporations are using the 340B program to increase their revenue, diverting funds from the populations that need it the most. There are several ways entities can become eligible for 340B. Most commonly, this is done by reaching a disproportionate share, or DISH percentage, of 11.75%. Evidence shows strategic corporate behavior where hospitals aim to meet, without exceeding, this bare minimum share of low-income patients to qualify for 340B. For comparison, my hospital's DISH percentage is nearly 80%. We frontline clinicians in safety net hospitals see these corporate entities claim their DISH status, yet they engage in predatory behavior such as aggressive debt collection or turfing patients when they realize they're uninsured or underinsured and sending them to us. These consolidated hospital systems may be officially nonprofit, but they sure act like profit-maximizing corporations. Data shows that newer entrants to the 340B program are expanding into wealthy areas with high penetration of private insurance so they can resell these discounted medications for a large profit. They claim that the extra revenue is for various programs to help the poor, yet there's zero evidence of this. In reality, these are consolidated, bloated, inefficient systems gaming a benefit program that was meant for the safety net. If they're so inefficient that they need a subsidy, we should be having that debate instead, not discussing how much they should be allowed to game the 340B program. If you come to my hospital's emergency room, you'll see why a true safety net hospital needs this program. Our patients suffer from complex diseases and lack basic social support networks, nutrition, and transportation. Meanwhile, the other hospitals in the area, instead of having an overflowing emergency room, the lobbies look like four-star hotels, yet they also receive that 340B discount. Abuse of the 340B system has led to pharmaceutical companies increasing list prices on drugs and trying to claw back benefits, such as restricting which medications can be distributed at off-site pharmacies. These restrictions are certainly understandable given the abuses of the program, but they have the unintended consequences of harming hospitals that truly need the discount. Mass abuse of the program has weakened it for the patients it was intended to serve. The program acts as a transfer of funds to CEs from private insurance, Medicare, and even Medicaid. The transfer of funds from private insurance and Medicare is well documented, with billions of dollars funneling into the revenue streams of the CEs. Even Medicaid transfers wealth to CEs when a state program forgoes the Medicaid drug rebate program due to prohibitions on duplicate discounts. A recent report from the California Legislative Analyst's Office found that CEs' drug charges to Medicaid managed care organizations were much higher than the state would pay under fee-for-service. The state reacted by carving 340B drugs out of Medicaid MCOs and reclaiming the MDRP, saving California millions, if not billions of dollars annually. The 340B program incentivizes consolidation, giving a competitive edge to 340B hospital child sites over independent practices, which are not eligible for the discount despite serving the exact same patient population. This contributes to the steady, targeted destruction of independent physician practices and further drains funds from payers as areas with higher healthcare consolidation see higher healthcare costs. To restore the 340B program's integrity and ensure it serves its intended purpose, we should consider increasing the DISH percentage required for eligibility. The current cutoff is arbitrary. DISH calculation for 340B should also include outpatient visits, incentivizing hospitals to create outpatient services for DISH patients instead of relying on inpatient numbers alone. There must be more transparency in the program. Reporting requirements should be simple, difficult to game, considering that safety net hospitals don't have extra resources to hire unnecessary administrative staff. Lastly, and I would say most importantly, the benefit should follow the patient. All this talk of which institution deserves the discount is nullified if we simply let the patient decide. This approach would empower the patient, letting them choose where to take this powerful discount, incentivizing institutions to attract those patients. Far too often in healthcare, we fund institutions over patients. This must change, and the 340B program is a great place to start. While I certainly think my hospital provides outstanding, culturally competent care, this isn't about me or my hospital. This is about empowering patients and letting them control where they get their care. So let's mindfully reform the 340B program and consider funding patients and not institutions. Thank you.
Thank you, gentlemen, for yielding back. Now recognize Ms. Veer for her 5-minute opening statement.
Thank you, Chairman Griffith, Ranking Member Castor, Chairman McMorris Rogers, and Ranking Member Pallone, and members of the committee. I appreciate the opportunity to speak with you about the value of the 340B drug program. As the Congressman said, my name is Sue Veer, and I have the privilege of serving as the CEO of Carolina Health Centers, which is a federally qualified health center that serves as the primary care medical home for 26,000 patients. Our service area covers 3,708 square miles and 7 rural counties. We operate 16 medical practices, 2 community pharmacies, and a farm worker health program. Our services also include early childhood services, behavioral health, substance use disorder treatment, oral health care, and enabling services that address the social determinants of health. We strongly believe that pharmacy is a core component of a primary care medical home, without which we would not achieve optimal healthcare outcomes. 340B is critically important because it enables us to provide affordable prescription medication for low-income, uninsured, and underinsured patients that we serve. In some cases, we're discounting prescriptions below the 340B cost. In addition, the 340B contribution to our operating margin supports healthcare services that would otherwise be unavailable in many of the communities we serve. My written testimony outlines many of those. The one that I will mention that is really near and dear to my heart are those early childhood services that are otherwise unfunded, because we're building the health of the future generation. Also, Congressman Duncan mentioned our LC4, which has the highest rate of uninsured patients of any of our practice sites. I'm here today because the stability of the 340B program is at risk, and it's our patients that are suffering. 340B covered entities and pharmaceutical manufacturers have begun treating each other like adversaries instead of partners, in large part due to three issues. First, the stakeholders have purposes and priorities that create the lens through which they see this program, and they are very polarized. For example, manufacturers see the program as a liability, where we covered entities see it as an asset. Growth in the 340B program has also driven the stakeholders towards an adversarial stance. Manufacturers naturally view growth of the program as increased liability, while covered entities see it as the opportunity to take care of more patients. Lack of clarity in the 340B statute has left the door open for manufacturers to arbitrarily impose conditions and restrictions on the 340B pricing that have been nothing short of devastating for many of our health centers. Many across the country are reducing services and closing practices because of losses to their operating margin and the increased burden administratively of responding to the conditions of participation. Carolina Health Centers has the benefit of having an in-house pharmacy, and we have agreed to comply with some of the manufacturer's restrictions and submission requirements. Even so, our chief pharmacy officer last year estimated the reduction in our margin from our pharmacy was $667,000 annually, and an estimated additional 0.6 FTE of workforce time was needed to comply with the data submission requirements. This represents nearly $700,000 that is being taken away from funding those very important services. Lack of clarity has also enabled the emergence of covered entity practices that are not consistent with the intent and safety net purposes of the 340B program, which has further escalated the manufacturer's efforts to contain the growth of the program. I personally believe, and it's my experience, that the vast majority of covered entities function as good stewards of the program. But despite the preponderance of good stewardship, lack of clarity has resulted in some practices that can be considered abuse of the program, and not surprisingly, those bad actors have garnered far more attention than the good stewards of the program. We have to find a path back to partnership. We have to not be adversaries. The current state is extracting a heavy toll, and that toll is being paid by our patients. A solution must be comprehensive and address the multiple areas in which the statute lacks clarity, and it can only come about when diverse stakeholders come together. We have seen a movement towards mutuality in the introduction of the 340B Access Act, as well as the discussion draft that has been circulated by the Senate, the Sustain Act. And it's critical that we work through these proposals to achieve a viable solution. I included in my testimony a number of elements that solution should contain. Thank you.
Thank you. Now recognize Dr. Smith for his 5-minute opening statement.
Okay, I think it's on. Chairman Griffith, Ranking Member Castor, and other members of the committee, thank you kindly for inviting me to appear at this hearing. I've been focused on 340B for several years now, and it's gratifying to be able to offer my perspective. My wife is in the audience today, and she can confirm that I've put her to sleep many nights rambling on about 340B over the last couple of years. Let me open by stating that I believe the 340B program is an important component of the nation's safety net, and for some community-based hospitals, it provides an essential financial lifeline, full stop. That said, it is important to point out that a great deal of the program's resources are now being captured by its vendors. For-profit pharmacy chains and PBMs, for example, are now very active in the program and make billions in profits from 340B. And some hospitals, but not all, have focused on serving wealthier communities because these communities are more likely to have a population with more generous insurance. The 340B program's deep discounts can be more easily arbitraged in these wealthier communities because hospitals can buy drugs cheaply and get reimbursed generously through Medicare or private insurance. The hospital's ability to buy low and sell high can create misaligned incentives that tend to steer the 340B program off its mission of serving vulnerable populations. It is also wrongly asserted by some that the 340B program involves only drug makers, hospitals, and clinics. I'd like to point out there are other stakeholders in the healthcare systems that are adversely impacted by 340B. For example, there's no statutory requirement that uninsured patients receive their drugs at the discounted price. And so some uninsured patients are charged full price at the counter of a hospital's 340B pharmacy. This has been confirmed by the OIG and GAO. Second, underinsured patients, for example, those with a high deductible, may pay more out of pocket than the hospital had paid to buy the drug. Third, another stakeholder that loses out because of 340B is the taxpayer. Some assert that the 340B program does not use any taxpayer funding. This is a bit misleading because when a hospital purchases a drug under the 340B discount and then bills Medicare at the Part B rate, a hospital can pocket an enormous spread at the expense of the taxpayers. This is particularly true for oncology drugs. Another fourth set of stakeholders that are facing challenges from 340B are community-based physician practices, especially certain specialists. For example, community-based oncology practices have difficulty competing against hospital outpatient facilities because the community-based physicians must pay commercial prices for their oncology drugs, while 340B hospitals can access the discounts. This has caused rapid consolidation of some physician practices under hospitals, which creates fewer treatment options for patients. And finally, we can't overlook employers, especially small employers who struggle to provide health insurance for their employees. When an employee is treated at a 340B hospital, the employer or its health plan may be charged full price for a drug that was purchased by the hospital at a deep discount, sometimes even purchased for pennies. The situation of these stakeholders makes it clear that the 340B program reform is needed. The question is where to begin. My recommendation would begin to start with simple transparency. Despite the massive size of the 340B program, $124 billion in sales last year at list prices, details on how the program actually operates are quite opaque. The legislative intent of the program was clear: provide 340B covered entities with additional revenue so they could serve more low-income and uninsured populations. Despite this clear congressional intent, we simply have no idea how much additional revenue individual hospitals secure through the program, and the data on how hospitals spend this additional revenue is somewhat unreliable. Without knowing how much money hospitals are securing from the 340B program, and without knowing exactly how they're spending that money, how can we judge the effectiveness of hospitals that are serving vulnerable communities and populations? My view is that individual hospitals should be required to disclose how much revenue they secure through 340B and how much of that revenue they spend on charity care in their community under a uniform definition of charity care. The goals of the Congress in creating the 340B program were very worthy: bring incredible innovations and discoveries of biopharmaceutical laboratories, as well as quality healthcare services to disadvantaged populations who otherwise could not afford them. I urge Congress to return to this program and to these important goals. I'm happy to take questions later. Thank you.
Thank you. And last but not least, for 5-minute opening statement, Mr. Perry.
Good morning, Chairman Griffin, Ranking Member Castor, and members of the subcommittee. I am Matthew Perry. I am the President and CEO of Genesis Healthcare System in Zanesville, Ohio, and I'm honored to be here today. Genesis Healthcare System is the largest care provider for the 235,000 people living in our rural six-county region of southeastern Ohio. Our patients face significant economic disadvantages and health challenges. Nearly 1 in 5 live below the poverty line, and 1/3 are on Medicaid. Our 340B eligibility is tied to our mission to serve them. Genesis qualifies for 340B by demonstrating that we are a disproportionate share. We serve a disproportionate share number of Medicaid or low-income Medicare patients. Our DISH percentage is 17%, and we recertify with HRSA annually. 340B is a lifeline for Genesis. Government health programs chronically underpay for our care, and we rely on 340B savings to fill the gap. We save about $56 million a year through 340B discounts. Our total patient service revenue last year was $786 million, and our operating margin was only $1.5 million. But without one-time COVID-19 grants we received that year, we would have been $13 million in the red. 340B is the difference between us operating a razor-thin positive margin or an unsustainable deficit. Without 340B savings, Genesis would not be able to continue to operate. Like all 340B hospitals, we generate savings when we use 340B drugs for insured patients. We invest all of the 340B financial benefit back into patient care. Some 340B savings help reduce patients' healthcare bills as well. We provide more than $3.5 million in free or discounted prescriptions. We also provide more than $75 million in uncompensated care. That's charity care, bad debt, and public program underpayments, including Medicare, TRICARE, and others. 340B also helps fund specialized services. Genesis is our region's only provider of high-acuity cancer care, neurosurgery, open-heart surgery, and advanced electrophysiology. Our specialized clinics provide endocrinology, rheumatology, pain management, and anticoagulation care. We generate 340B savings on the outpatient side, but can use them for inpatient needs, such as our inpatient behavioral health center and the region's only trauma center. All this requires significant investments in facilities and staff. 340B savings enable us to hire and retain top specialists. We lose millions of dollars each year supporting our 325 plus employed medical group, and we recruit 95% of the physicians who practice in our community. Amid high prices for labor, supplies, and drugs, 340B savings are more crucial than ever. Since 340B became law in 1992, tremendous advances have occurred in outpatient care and expensive life-saving drugs. As those have grown, 340B savings have also grown. So too have grown the medical needs of our patients and the level of services we must provide. We have seen the harmful effects of 340B restrictions. Since 2020, many drug makers have restricted discounts through our contract community and specialty pharmacies. We have lost $5.7 million in 340B savings from our historically contracted pharmacies, helping make 2022 and 2023 the toughest financial years in our history. We try to serve patients through our own retail pharmacies, but they cannot fill all those prescriptions due to limited distribution networks and PBM restrictions. 340B works so well because it does not restrict on how we use our savings. We can direct resources where our patients need them the most. It is critical that this flexibility continues. I'm aware of proposals to redefine 340B and limit discounts to drugs that to only treat low-income, uninsured patients, or to base them on provider levels of charity care. This would dramatically shrink 340B and devastate our hospital. It likely would put us out of business. If patients in southeastern Ohio lost access to our service and support, they would need to travel far away to receive that care. Many would not be able to make that trip. As Congress debates 340B's future, I urge you to carefully consider how much critical patient care 340B makes possible. Thank you for the opportunity to be here today on behalf of Genesis Healthcare System and the patients that we serve. Thank you.
Thank you, and I thank you all for your testimony. We will now move into the question and answer portion of the hearing, and I will begin the questioning and recognize myself for 5 minutes. Dr. Smith, I'm going to use you as a tool in this hearing, so I appreciate you being available, and I was appreciated hearing how you love the issue so much that you generally bore your wife into slumber. But I do think there's some questions that it might be somewhat helpful to members, although most members probably already know this, but certainly for the folks watching probably late tonight or tomorrow or sometime next weekend on C-SPAN in some ability to understand. So in order to get the full picture, I'm going to ask a few questions about hospitals are reimbursed under the 340B program. And for this line of questions, I'm going to ask that you answer just yes or no so we can get through the basics. A 340B covered entity is allowed to purchase a drug at a discount in accordance with the law.
Yes.
Hospitals then create savings by charging commercial payers and Medicare at the same rate they would be reimbursed had they purchased it through either commercial payer or through Medicare.
Yes.
Commercial insurance reimburses at a higher rate than Medicare.
Yes.
Medicare typically pays higher rates than Medicaid.
Yes.
So a hospital generates revenue from the 340B program by purchasing the drug at a highly discounted price than getting reimbursed by the payer, like a commercial health plan or Medicare, at the higher rate of what they would bill the payer as if it bought the drug at the regular commercial price.
Yes.
As I've always understood it, and I think you said this too, the savings from this are what covered entities are supposed to use for health care for underserved patients. Would you agree with that?
Yes.
All right. Now, hopefully, we didn't put everybody watching at home to sleep with that, but I did think it was important that we get that out on the table. Dr. Smith, Medicare beneficiaries are required to pay a 20% cost sharing for Part B items and services. Drugs administered by covered entities, hospitals, in-outpatient departments are covered by Part B. Do Medicare beneficiaries pay their 20% cost sharing based off the acquisition price of the drug, or do they pay their 20% cost sharing as if the covered entity bought the drug at the regular price?
I would say generally they pay as if the covered entity bought the drug at the regular price.
Okay. And hypothetically, if you had Hospital A that had a pay mix of 90% public and uninsured patient and only 10% commercial pay versus Hospital B that had a payer mix of 50% commercial and 50% public or uninsured, which hospital would be able to generate more revenue from the 340B program?
The hospital with more commercial patients, for sure.
And could you please explain?
Well, again, as I said in my testimony, the way revenue is generated through this program is the hospitals arbitrage the discount. They buy it low, and then they sell it high to a commercial insurer, to Medicare, or to other payers. And that's how they generate revenue. That's arbitrage. That's the classic Wall Street arbitrage.
And so basically, if you have a 50% mix of commercial payers, what's going to happen is that you're able to get a lot more money out of that because you're charging those commercial insurance companies for the full freight and not actually having to pay.
Yes, and
that
that's
for
one of the
medicine.
misaligned incentives in the program, in my view, is that it tends to, hospitals tend to want to bring in more patients with good insurance, and that's
Right.
that's not the legislative intent of the program.
As opposed to going into underserved areas where they can't get as much. All right. Dr. Giorgio, and I think that's what happened with Bon Secours in Richmond.
Absolutely.
Dr. Giorgio, the facility you work for or work in provides care for a large number of low-income and uninsured patients, nearly 80%, as you stated in your testimony. There are patients the 340B program is and should be specifically targeted to. The part of Don McEachin's district that the New York Times reported on is an economically stressed area, which I imagine is similar to the patients you serve. Can you elaborate on how the 340B program is needed to keep your doors open and how important the program is for you?
Yeah, low-income patients simply, they take more resources to care for. These patients lack basic social support networks. They lack access to basic things like nutrition and transportation. They have much extended hospital length of stay because they don't have the support networks to safely discharge them. So these patients take just a lot more resources to care for. And when you're a hospital like mine that predominantly serves these patients, it simply takes more resources to care for them.
And if a wealthy hospital with large share of commercial patients use the program, does that negatively impact you all?
It does in that they are turfing patients to us that should be treated by that program. So they're given this large discount, and then they send the patients to us anyway.
And one final question. If you move the patient or if you move the services completely out of Richmond and you move it, say, 8 to 10 miles away, a lot of those underserved patients can't get there, can they?
Right. Most of them lack basic transportation.
So they're not going to be able to go get the services even if they're still somewhere in the area.
That's correct.
And that's sometimes what happens. I yield back and now recognize Ms. Kester for her questioning.
Thank you, Mr. Chairman, and thanks to all of you for what you do every day to take care of hardworking Americans and their families. What I heard from the panel is uniform support generally for the 340B. I've heard the word lifeline used a couple of times, so I think that's important to know. No one on this panel is interested in eliminating 340B. I hear a lot of ideas for strengthening the program and reforming it. What I hear from my providers at home is that it's simply fundamental to be able to extend care and provide flexible services to those who need it. And that flexibility is very, very important to them. But Mr. Perry, can you go back over some of the stats you provided? How much does your organization, health system in Ohio, save due to 340B, and how do you put those savings to work?
So we save about $55 million a year from 340B, and basically it has become a an absolutely fundamental component of our reimbursement structure as a health system. Enables us to provide care for everybody in our region. 33% of the people who live in that 6-county area that we serve have Medicaid as their insurance. And those programs are so underfunded, it enables us to be able to sell those drugs, be able to get the discounts, and then reinvest it back into making sure we can recruit the physicians and provide the services to everybody.
Give us an example of something that you're providing that Medicaid reimbursement directly does not provide, that you're able to do because of 340B.
A great example is our Cancer Care Center. We have an amazing cancer care center at Genesis. It was developed over the last 14 years. We would not be able to provide that service if we did not have 340B. We save a lot of money through the program, and all of that goes back into recruiting the physicians, making sure we have all the technology.
Is that difficult to do right now?
It's very difficult. It is very difficult. Absolutely, yes.
Ms. Veer, thank you so much for your testimony. I'm very intrigued about how you're able to use 340B to help provide early childhood services. That's not something that you typically think of with a health system and clinic. So tell me about the gaps you're able to fill because of that.
Certainly, thank you for that question. And actually, our pediatric program was what drew me to the center 18 years ago, because we were that center was a pioneer in recognizing that you need to integrate early childhood services and parenting education and support into a pediatric home. You can't, we have to go outside of the bounds of the traditional pediatric home and understand how children are living in their homes and help them there. So we operate 4 evidence-based programs that are home visitation programs. Unfortunately, they have very strict criteria. They are funded by the Maternal Infant Early Childhood Home Visitation Program, but they have strict eligibility criteria, which means a parent may come to our pediatricians and have a difficult problem adjusting to something in the home, and they need the work of perhaps a behavioral health services, or they need the work of somebody in early childhood services to help with developmental milestones. The contribution 340B makes allows us to make sure no family is left without those services.
And that's been fundamental as part of your your care system for many years, and it's because you're able to do it because of 340B.
We're able to do it because of 340B. We're also thankfully able to do it through the McVie funding, and now HRSA has provided some funding. But we've been able to really increase our access to all families because of our contribution from 340B.
And that's due to what I hear from my providers at home, that flexibility that 340B provides. So I appreciate your recommendations for some reforms, but you're not recommending in any way that we kind of scale back the ability of health systems to have that flexibility to determine what the needs are in their community.
No, I would not want to scale back the flexibility, because I agree every community is different and the needs of every community health center is different. What I do think is that we need to start with a fundamental threshold definition of what patient eligibility is. And that has to be linked to direct patient care provided by the covered entity. And I agree with my colleagues that we need to have transparency. The flexibility is important, but being transparent about what those services are is equally
And
important.
giving HRSA the ability to provide that oversight is important too.
Yes, ma'am.
Yes, okay. Thank you so much.
Jana Lee yields back. Now recognize the gentlelady from Washington, Ms. Rogers, Chair of the full Energy and Commerce Committee.
Thank you, Mr. Chairman. Transparency is foundational to ensuring that we have accountability and trust with the American people and how their tax dollars are being utilized. It's also critical to our efforts to support patients and lower costs in our healthcare system. I'd like to start with Mr. Perry. Do you annually report the total amounts in net savings that you will receive from the 340B program?
Yes, we do.
Is there any reason why we shouldn't require that type of transparency in the program, and what are the best transparency metrics?
I think we have a tremendous amount of transparency already. The vast majority of covered entities that I'm aware of put together something like this, which is our 340B accountability report, and basically it gives us the ability to share with anybody exactly how much we save and then what we do with those savings.
Okay, thank you. Ms. Veer, same question to you. Do you annually report the total amounts in net savings that you receive from the 340B program?
Yes, we do. We annually report to our board, and we also have federal reporting requirements related to our Universal Data System report with HRSA.
So would you speak to what you believe the best transparency metrics are for the program?
I think for me, the best transparency metrics would be being able to outline the population served. And so, for example, we get into a lot of discussions about the uninsured, and I think it's equally important to look at our underinsured population that we serve, because they may be insured but live at or below 200% of the federal poverty level. And so just saying we serve this many uninsured patients is not adequate. I think it's important to look at the overall profile of the patients that are served, and then being able to, we use a simple metric where we have the even line, and we have programs and services that operate above the line, producing a contribution to our operating margin, and programs and services that operate below the line, which require the support from those other services. I think even being able to do that is useful.
Thank you. Dr. DeGiorgio, this committee's been increasingly concerned by perverse incentives that lead to consolidation. One such policy that we've examined has been site neutrality. Can you compare for us how 340B may be similar to site neutrality issues in encouraging hospital systems to acquire independent physician practices?
Yeah, there's a large targeted effort, I think, to put independent physician practices out of business, and site neutrality certainly contributes, as well as 340B. There's a competitive advantage, right? So if one oncology clinic can purchase drugs at a 340B discount and the other oncology clinic can't, or rheumatology or neurology or whoever's doing these high-priced infusion therapies, the one that can purchase the drugs at a discount is going to have a competitive edge. They're going to have more revenue that they can put into making their facility look nice, outreach efforts, advertising, et cetera, and simply they're going to put that other practice out of business. They're either going to have to shut their doors or they're going to acquire them. There's a large push for PE, private equity now, to help rescue some of these practices, but 340B certainly contributes to consolidation.
Thank you. Dr. Smith, the rising cost of health care and health insurance is a top priority for employers these days. Should employers be allowed to review drug acquisition cost data from covered entities and be able to design health insurance plans for their employees that take advantage of lower cost?
That is a challenging question. I don't think I would support spreading the 340B price to virtually every commercial entity. That would weaken innovation significantly. There are large portions of the pharmaceutical market and biotech market that are already price controlled. VA, Medicaid, increasingly Part D, and 340B. And if you were to expand that price to large sectors of the commercial market, I think you would see innovation significantly weakened in the biopharma research area.
Well, my question is more around the transparency piece of this, and whether you believe or you think there would be a value for employers being allowed to review the acquisition cost data.
I think there would be some value to that. I think a number of employers on certain drugs are being overcharged, to be honest. I mean, there are penny price drugs that cost $7,000 a month that hospitals can acquire for a penny.
Okay.
I think employers would be interested to know that.
Right, okay. Thank you, everyone. Appreciate you being here. I yield back.
Chair yields back. Now recognize Ms. Schakowsky for her 5 minutes of questioning.
Thank you, Mr. Chairman, and thank you for this discussion. I've been in the Congress for quite a number of years, 25, and I was here when we saw the Henry Waxman help to get 340B, and how much good it did to provide the healthcare, the pharmaceuticals for low-income people and for low-income communities. It's been so incredibly important. And I'm not going to argue that there may not need to be some changes, but I know that some of the changes that have been suggested and implemented have been a real detriment to places in my community. I am not worried about Big Pharma and the money that it's making. We know, as Congresswoman Castor mentioned, this is the most profitable industry in the United States of America, bigger than big tech and big oil, and they're doing just fine. But we want to make sure that providing the pharmaceuticals, the health care for low-income people continues. And I just wanted to mention what's going on in my community. In Evanston, we have a community health center where, due to some of the restrictions that have been made, we find that the closest available pharmacy to be able to access the money is an hour drive away from what it used to be. What does that mean? That low-income people don't go and get the drugs that they need, because it is now required to go from Evanston, Illinois, all the way down south in the city of Chicago. So they simply don't go at all. So my question, I begin with Mr. Perry, and so I wanted to know, how does the fact that these some of these drugs are not available where they used to be, and how does that affect both the consumer and the healthcare center?
Yeah, so the fact that we can no longer get a lot of drugs through our contracted pharmacies has, again, as I mentioned in my testimony, that we lost about $5.7 million reduction over the last 3 years, and in what we can actually save. And these pharmacies are located, the ones that we still do have, the specialty pharmacies, are located, some of them hundreds of miles away, and that's the only place that you can get those medications. It's not that we're trying to go a long way away to get them. We get them from someplace that's hundreds of miles away. That medication is either sent directly to the patient, or it's sent directly to us through mail order for us to be able to infuse it for the patient.
So how has that affected the effectiveness of the program?
It's made it much more difficult. The fact that the continued constriction of these contracted pharmacies just reduces the amount of savings that we can generate to be able to reinvest back for our patients and take care of our patients.
Well, I know that our community health center has really suffered. In fact, is in deep financial trouble, because they are not getting the benefits that they need from the program.
Yeah, we're a rural dish organization, and patients have to travel a long way to get their care if we were not there. So we are a very vital component of being able to have patients to be able to get the medications that they need locally.
Now, that didn't used to be, though, right? You were able to access much closer.
Yeah, well, we used to be able to access a lot more drugs through these contracted pharmacies, yes.
Exactly. I did have just a quick question for Ms. Veer. I know I was asked by my community health care center to ask you how the community health centers use 340B allows money that then can be used for transportation, maybe for nutrition, if there's additional money that's available.
I think that's Thank you to your health center for asking that question. It's a really important component. We are in a very rural area, and we have a lot of people with food insecurity. I know there are many health centers that are starting food programs where they have food banks. I just saw recently on social media a community health center that was doing boxed lunches and giving those out to the patients. We don't have any resources for that, so 340B, the contribution helps with that. We ourselves, we're erecting, I can't even remember, blessing boxes. They're called blessing boxes, and we're erecting them, just heard about it last week, in front of our practices, and we then fill them with things, canned goods, pasta, that kind of thing, and people are welcome to take from them. Again, our employees are donating money for that, but we'd like to expand that program to address food insecurity. It's a huge problem, and it's contributing to a lot of our health issues like obesity and hypertension and everything that goes along with that.
Well, I want to thank you, and I want to thank the chairman for his indulgence in letting me go on beyond my time, and I yield back.
Gentleman yields back. Now recognize Dr. Burgess for his questioning.
Thank you, Mr. Chairman. As you know, this subcommittee has looked into this issue for a number of years. I don't know that we've solved any problems. We may have created some along the way. But Dr. Smith, I just have to ask you, because you referenced your website and your transparency tool that you have on your website, so I couldn't help myself. I went to it, and now I've learned some things that I don't understand, because you have your fact sheet for the state of Texas. And under the Key Points tab, Texas low-income taxpayers are required to utilize for-profit pharmacies in Massachusetts. I wasn't aware of that. How is that happening?
One of the most confusing things about the 340B program is the location of contract pharmacies, and you can discover that on our website. We downloaded the HRSA data. You have large hospital systems that have hundreds and hundreds of contracts for contract pharmacies, and some of them are thousands of miles away. There's a hospital in Boston, a large hospital, that has a contract pharmacy in Hawaii. I don't understand the reason for that. It's very opaque to me. You're treating a low-income population. They typically don't vacation in Hawaii. I don't understand what's going on with the number of contract pharmacies. Some people have said that they're mail order. There's a study that came out in JAMA last year that indicated that 99% of the contract pharmacies are brick and mortar retail pharmacies. So it's very confusing to me about what's going on with contract pharmacies.
Yeah, I see, Mr. Perry, you want to weigh in, but let me just stay with you, Dr. Smith, for a moment on the issue of contract pharmacies. I mean, I'm from Texas. We never explain anything by coincidence if there's an adequate explanation in conspiracy. Contract pharmacies really exploded through not legislation, but through rulemaking at the agency in early March of 2010, coincidentally about 2 weeks before the signing of the Affordable Care Act. Now, I don't know if the two were related. I don't know if this was part of some deal that was offered, hey, if you don't complain about this bill we're going to pass that is going to negatively impact your bottom line, we'll make it up to you in another location. But I do have that uneasy feeling that from your graphs on your site about the timeline for contract pharmacies, the explosion occurs after an inflection point of March of 2010. Am I correct in that assumption?
That is correct. You can see the data on our website. It just goes, it's a hockey stick up, and it's hard to explain. I mean, the previous rule was that if you don't have an in-house pharmacy, you can contract with one pharmacy outside in the community. That seemed like a reasonable rule to me. And then suddenly HRSA just said, nope, you can contract with an unlimited number of pharmacies. And now some hospitals are contracting with pharmacies thousands of miles away. It's hard to understand. I'd heard many different explanations. None of them made great sense to me.
Yeah, and I'll just throw in another fact, and it's possibly not related, but if you superimpose insulin prices on that same timeline, the same inflection point occurs. Insulin costs much more today than it did prior to 2010. Again, and I'll leave you to draw your own conclusions. Mr. Perry, I know you want to speak to this.
Thank you, Congressman Burgess. Very quickly, so it's very simple. There are two types of contract pharmacies. One that are local retail pharmacies. We have 7, okay? Local retail pharmacies that we contract pharmacies. And those we contract with to make sure that patients can get their normal medications here locally close to where that they live, okay? That's one section. The other section are specialty pharmacies, and they are scattered all over the country.
Okay, fair enough. I take your point.
Yes.
Doctor, I just wanted to include you in this discussion as well. In October of 2019, this committee marked up a bill called H.R. 3. It was to nationalize pharmaceutical industry across the country. Didn't pass, but parts of it were included in the Inflation Reduction Act. I argued for an amendment at that time, which had exactly your point in 340B. The money should follow the patient. If we really wanted the transparency, if we really wanted to help the person who was less well off, the money would follow the patient. I still believe that. Is there a way to incorporate that into what we're working on today?
I mean, that's a difficult conversation. I think there certainly is. There could be different thresholds for dish institutions. If they fall below that, the patient could get something like a pharmacy benefit card that could follow them, and they could get the discount that way. It could be combined with reforming the MDRP so that it's a one-size-fits-all pharmacy discount for low-income patients. Certainly a difficult conversation, but I think that's why we're here.
Yes, sir. Thank you, Mr. Chairman. I appreciate your efforts on this. I know you've worked on this a lot over the years, and I hope that you will continue to do so after I'm gone.
And I think we probably will. Dr. Burgess, as many of you know, is retiring after this term, so we're going to lose a real asset. That being said, now recognize Mr. Pallone, the ranking member of the full committee, for his 5 minutes of questioning.
Thank you, Mr. Chairman. I wanted to focus on the differing accounts we've heard in today's testimonies about how covered entities use their 340B savings. And they generally report that the savings provides financial support that are used to maintain, improve, and expand services to their patients, who are often disproportionately low income, underinsured, or uninsured, and that the services provided can differ based on the needs of a particular institution and community. But let me start with Mr. Perry. How does your organization use 340B savings to further the intended mission of the program? I know you've talked about this a little, but if you'd, give us more information.
Sure. So we use it to be able to support our oncology program, our trauma center, to be able to actually recruit and to be able to support the wide base of specialists that we have that serve our community. If we did not have the 340B program, the service area that we operate in would be a medical desert. Physicians just do not pick up and relocate to our area. So it is a foundational for us to be able to have all of those services even available in the first place. And it also gives us the ability to give discounts directly to patients so that every patient can get their medications who needs it.
All right. And then what would be the consequences for Genesis or its patients and similar 340B entities in the absence of the savings provided by the program? You talked about that a little too, but if you would develop that.
So in the absence of 340B, our organization doesn't work. It's just that simple. We are not in business. And I'm very plugged into and know many of the CEOs around the state of Ohio who run organizations similar to ours in rural areas, and they too are DISH organizations. And they are, it's a foundational component of the reimbursement system because Medicaid, Medicare, and we take care of our veterans. That's important to us. All those programs do not even come close to covering the cost of care, and without 340B, we just don't function.
All right. Well, thank you. I'm just going to say, Mr. Chairman, that I really think our efforts should be focused on enhancing the effectiveness of the program to provide the greatest patient benefit, and efforts to simply make the program smaller and more complicated, I think, would be counterproductive to that goal. So I have one more question to Ms. Veer. How does the 340B program help Carolina Health Centers provide more comprehensive services to its patient population, if you will?
Thank you for that question. And I'll kind of echo what my colleague said. We wouldn't exist as a primary care medical home without 340B. First of all, let me start by saying that federally qualified health centers are responsible for providing an array of required services in the HRSA program expectations, but they're not all reimbursable services. And before 340B, we could not, one of those services is for affordable prescription medication or pharmacy services appropriate for the patient population we serve. Before 340B, we could not provide pharmacy other than directing people to go to the $4 Walmart, their list. There's so many other things. For example, behavioral health is a required service for an FQHC, and it's important. It's essential to the overall health of our patients. And for my health center, we have a pretty robust behavioral health program, but I would say 80% of the adult behavioral health services have no source of reimbursement. And those patients could be trying to go into the state system, but the wait is too long. So we could not meet the expectations of a primary care, and particularly a patient-centered primary care medical home where you're looking at the whole person.
No, and I appreciate, both of you explaining how, this is essential. I mean, I guess the bottom line, I would say, is that significant cuts to 340B are going to would clearly impede the ability of all of you and, 340B covered entities to provide a full range of services, or maybe not any services at all, is the bottom line. So in any discussion of changing the criteria, we have to be careful to avoid any approaches that result in reducing patient access to providers. I mean, patient access, is increasingly a problem for everyone. I don't care how wealthy or poor you are, but obviously for people who are, low income or underinsured or uninsured, it's even more a problem. So thank you all. Thank you, Mr. Chairman.
Thank you. Now recognize Mr. Duncan of South Carolina for his 5 minutes of questioning. And I assume your hearing is still going on.
It is, yes, sir. As you know, as a chairman, sometimes it's hard to be in two places when you're locked down in a chair. But Ms. Veer, thanks for being here today. All the witnesses, I wish I would have been here longer to hear the testimony. From what I've heard, it's been interesting. Ms. Veer, are there any successes at Carolina Health Centers you'd like to showcase in front of this committee, which other areas of the country could benefit from?
Certainly, and you mentioned one in when you introduced me, and that is the short name is LC4, but it's Lawrence County Community Care Center, and I think it's been 10 years since you cut the ribbon on that project. But it was a community hospital that had built a new ER, and they came and asked, what should we do with the old ER? And my question to them was, what % of the patients using the emergency department now are using it for basic primary care, and they don't have a primary care medical home? And the number was shocking. It was like 76%. And so we worked together to build immediately adjacent a primary care medical home where patients can be triaged in the ER. Oftentimes, they're provided treatment because once the medical screening exam is done, it's only a matter of writing a prescription. But if they don't have a medical home, they're sent next door. And then and I would say probably 40% of the patients that are referred to us initially, they established with us, and that number has grown to about 60%. So we've created a primary medical home in a community, by the way, that has one of the highest rates of uninsured people and one of the highest rates of unemployment. So it's really critical. And 340B helps to promote that in two ways. One is we're able to provide those patients with affordable medications. And the other is, as I said earlier, that center has our highest rate of uninsured and underinsured patients. Consequently, we would not be able to cover the cost of keeping that practice open without 340B.
It keeps those patients from going to the higher cost emergency department for their treatment. Once they develop that community care center as their medical home, they can go there versus the ED, and that's great savings for the country.
And if you don't mind my adding, we bend the cost curve in the right direction for the entire healthcare delivery system, because once they're in a medical home, a true patient-centered medical home, we're reducing the use of specialty care, we're reducing inpatient admissions, and certainly we've reduced the use of the ER. So it's not just a savings for that patient or this health center, it's the whole healthcare delivery system.
Well, thank you for that, and I applaud what Lawrence County has done there. I want to shift gears. Mr. Chairman, I'd like to submit for the record an article, Inside the World's Largest AIDS Charities Trouble Move into Homeless Housing, and I'll cover that. I know y'all have to look at it first. We've seen troubling misuse of certain 340B grantees, notably AIDS Healthcare Foundation. Dr. DeGiorgio, I want to ask, what should Congress do to prevent abuses like AHFs that prevent others from using 340B for the good?
Yeah, I think we need transparency there. There's clearly bad actors. I know the one of which you speak in California. Transparency showing where these drugs are being purchased, who they're being purchased for, and who's paying it, and then what their revenue is. That should all be public knowledge.
Okay, thank you for that. Anything further we need to do there that you'd like to comment on?
No, thank you.
Okay, thank you. Ms. Veer, the 340B program is a lifeline for safety net providers in the district, as you said. They can invest their 340B savings into making medications more affordable and expanding access to primary care. Can you discuss or elaborate on specific examples of how the 340B program has positively impacted constituents in our community? We talked about LC4, but you have a broad region in the 3rd District. Are there other examples of that?
Oh, absolutely. We've talked about 2 already, and one is with our early childhood services, the ability to make sure that no family goes without those services because they're not reimbursable by any other source, behavioral health. But I think how it's impacted the constituents in the area is they now have, many of them have pharmacy services as an integrated part of their primary care medical home. In our pharmacy, the pharmacists have access to their medical record. They're able to bring that up. They're able to consult in the practice. So it's really a more complete integration of pharmacy into the primary care medical home.
Thank you for that. My time's expired. I yield back.
Thank you, Chairman Duncan. Now recognize Mr. Tonko for his 5 minutes of questioning.
Thank you, Mr. Chair. Our communities and constituents depend on the 340B program to provide comprehensive care to patients who are least able to find accessible and affordable health care for themselves and their families. These are the uninsured, the underinsured, low-income families, and those in need of specialized care. Facilities are statutorily eligible to receive 340B discounts if they show they serve a disproportionate share of these patients. In my community, I am grateful to the safety net providers, clinics, hospitals, and health centers who care for the most vulnerable patients in our communities. Like many places throughout the country, providers in our 20th Congressional District in New York are able to help my constituents as a result of the 340B program. For example, in my district, Whitney Young Health shared how the 340B program allows them to better serve some of the most vulnerable members of our community. And at Samaritan Hospital, the savings allow them to invest in community health, including preventative services, uncompensated care, community partnerships, and other efforts to meet the health needs of the uninsured, low-income, and other at-risk populations. These services help victims of crime, homeless people who needed treatment or temporary housing while ill, and people with food insecurities. Also in my district, Albany Medical Center shared the 340 program, and I quote, is underpinning all of our operations that would be deemed necessary to maintain our ability to provide care to our entire community. So, Mr. Perry, how does 340B enhance Genesis's services in your community, particularly given that it primarily serves a rural area of Ohio?
Yeah, so thank you, Congressman. I have multiple different examples of that. One is that it gives us the resources to be able to offer care at an exceptional level, a high level of quality. We were able to recruit very well-trained physicians. We have a technology platform that is kind of second to none. So it gives us those additional resources. It also gives us the ability to do things in areas that nobody else is going to provide. provide. So an example of that is behavioral medicine. Very underfunded, and it gives us that foundation to be able to provide that. I mentioned trauma care earlier. Prior to my arrival at Genesis 16 years ago, we did not have a trauma center, and it was the largest rural area. It was actually the largest geographic area in the state of Ohio without a trauma center. People were routinely not making it to the big cities. We used the savings from 340B to be able to develop a trauma center and be able to care for everybody.
Well, thank you for that. Mr. Perry, do patients in the area that you serve have many choices in terms of healthcare providers? And how might their choices be further limited if the 340B program were reduced or indeed eliminated?
Yeah, so choices, very few choices. So we are really by far the largest entity of providers in our entire 6-county service area. And if we were not there, again, our area would be a medical desert. It just would be. So, again, the only way physicians come to our area is if we bring them there. So we are the engine that enables the entire healthcare ecosystem to actually function.
Thank you. And Mr. Perry, we've heard concerns during today's hearing about the program's growth in recent years. My understanding is that part of the growth is driven by more participants in the program, which I think is a good thing given the patient population that the program serves. I also believe that the increased money paid out by pharmaceutical companies to program participants over time is in part a reflection of skyrocketing drug prices. So, Mr. Perry, is it correct that increases in prescription drug prices, which are set by the manufacturers, are partly responsible for the increase in the total dollar amount of 340B discounts?
Oh, absolutely, yes. When you look at the drug price increases, I keep going back to our oncology center. I mean, it's just astounding. So, our typical infusion services for chemotherapy, those drugs cost upwards of $15,000 a dose, and that has just increased and increased and increased, which increases the savings we get as well.
And so do you think it's a good thing or a bad thing that there are more entities enrolling in the 340B program?
I think it's a good thing to the extent that they are, you have entities that meet the requirements, right? That's what Congress intended. Dish organizations that deliver a high level of care to people that don't have the resources that enable those organizations to be able to sustain their mission. I think that's a good thing.
Well, during the COVID-19 pandemic, the entire healthcare system experienced strains on already limited capacity and financial resources, and that recovery continues today. That's why it was important that Congress acted to make certain that service changes caused by the pandemic did not threaten their continued 340B eligibility. This program is an essential part of healthcare in our communities across the country, and we should ensure it remains available. And with that, Mr. Chair, I yield back.
I now recognize myself for 5 minutes of questioning. Constituents in my district in Arizona, the Phoenix metropolitan area, go to a number of hospitals that use a 340B program. Banner Thunderbird Medical Center and Honor Health Deer Valley Medical Center are both in my district. Plus, close by is Banner Estrella Medical Center, Banner University Medical Center, Phoenix, Honor Health Johnson C. Lincoln Medical Center, Phoenix Children's Hospital, which is building a hospital right in my district, and St. Joseph's Hospital and Medical Center. Today's hearing is on topic. Because it has a significant impact on constituents in my district, particularly the over 250,000 senior citizens who have health care coverage under Medicare. Many of them depend on hospitals participating in the 340B drug pricing program for medical care. In fact, two of the largest hospitals in my district, Banner Thunderbird Medical Center and Honor Health Deer Valley Medical Center, are 340B covered entities. Banner Thunderbird Medical Center reports using the savings from the program to offer increased access to mental health treatments, extended clinical hours, and to hire additional medical and support staff. Many safety net providers report concerns about their ability to maintain operations without the program. Dr. DiGiorgio, sorry I messed your name up. In your written testimony, you mentioned that you believe Congress should change the eligibility standards hospitals must meet to qualify as a covered entity under the 340B program. Could you explain how increasing the eligibility percentage to qualify as a disproportionate share hospital would benefit patients?
It would ensure that this discount is going to the hospitals that truly do reach out and take care of disproportionate share patients. There's a lot of bad behavior by hospitals that claim DISH status and don't actually live up to that mission. They act more like large consolidated conglomerates. They do predatory debt. They go after patients for predatory debt. They transfer patients away from their hospital when they realize that they're uninsured or underinsured. And so holding them to a higher standard, I think, would help overall care. But in the bottom line, I really do believe that this discount should follow the patients, and the patients should be able to direct it. I believe in market forces, and I believe that allowing the patients to control where this discount goes would truly help them pick the best place that is unique to their specific needs.
And also to you, sir, do you think increasing the requirements for hospitals to become 340B covered entities, would it make it more difficult for low-income individuals to have access to affordable care?
No, I don't believe so. I think part of my recommendation was also including outpatient visits as well. And so by including outpatient services, that would encourage these hospitals to reach out to those patients and provide services to help them get their outpatient visits. Right now, outpatient visits are not included in the DISH calculation. And because of that, there's very little utilization, or utilization skews towards inpatient for low-income patients because they don't have access to primary care, because there's simply no incentive for outpatient clinics to reach out to these patient populations. Again, as I mentioned earlier, they have special needs in terms of transportation and support networks. So a lot of these clinics could be incentivized to reach out to these patients if that was included in the outpatient metric as well.
And do you believe what do you believe the role of contract pharmacies should be in relation to the 340B program?
I think if the DISH percentage was fixed and it was allowed to follow the patient, I don't see a problem with where they could get their medications. I think there's established hospital referral regions. The Dartmouth Atlas has this that describes a certain hospital's referral region, and simply limiting contract pharmacies to that referral region would be effective.
Thank you, and my time is almost expired, so I yield back. And I now recognize Congressman Peters for 5 minutes of questioning.
Thank you, Madam Chair. Sounds like I'm among a number of strong supporters of the 340B drug discount program, which helps low-income patients in San Diego and across the country access life-saving medicines at discounted rates. 340B is a promise to vulnerable patients that they will be able to access the medicines they need to survive, regardless of the cost barriers. When I talk to 340B providers in my district, they can show me what they're doing with their 340B savings and how they're reinvesting in underserved patients. But I think, as has been discussed, a growing body of evidence suggests that in some cases, covered entities aren't always helping the patients the way they should. For example, the New York Times found that Bon Secours Health System in Virginia used those funds to expand services in affluent neighborhoods at the expense of patients who really need it. In some cases, patients died. In other cases, low-income patients were hounded by hospitals to pay for health care that should have been free at the point of service, and that's unacceptable. Due to recent court decisions, the agency in charge of overseeing 340B unfortunately has limited authority to address some of the very fundamental issues in this program. And again, I've heard nobody say they want to get rid of this program. There's a little bit of a hyperbole about that. But unless we can come together and have a serious conversation to identify some consensus on 340B reform, I worry this entire program will continue to be legislated by the courts in ways that are beyond our control. Ms. Veer, can you speak to areas where you think there might be consensus among stakeholders to address conflicts and pursue reform in 340B?
I certainly can. Thank you for the question. I think I think there's consensus around the intent of the program. I think that was a concern a few years ago, but I do think we all believe that the program is more than just a drug discount program. It is really intended to build a strong and effective healthcare safety net. I think many of us, I don't know whether it's 100% consensus, but many of us believe that we could address some of the misaligned incentives with a very clear definition of patient eligibility and prescription eligibility that is really built on direct patient care relationships. We've talked a lot about contract pharmacy being codified, and certainly recognizing that contract pharmacies, if we get patient definition right, does it really matter where they go? Because we have contract pharmacies in place because of geographic differences, and we have contract pharmacies because of limited payer networks that require us to contract there. But we've clearly all talked about transparency and accountability, and I really think that it's critical that we have transparency about how this program is promoting health equity.
Thank you. Just to note, to underscore your point, both the GAO and the Inspector General have made disturbing observations that the current patient definition is overly vague and can lead to program abuse. And now it's even more doubtful based on a recent court decision, which you're familiar with, leaving the agency with few tools to govern the most critical aspect of the program. Can you speak to why, specifically why the patient definition is such an important part of getting this right?
For me, it's because it is that, I mentioned earlier at the beginning in my opening statement that we need a pathway to an effective partnership among all covered entities and the drug manufacturers. It needs to be, but there need to be guardrails that protect against the abuses. Patient definition is so important because we need that doorway through which those of us that are good stewards of the program can enter, and the patient definition, again, needs to be based on direct patient care relationships. But there needs to be recognition of the scope of service each covered entity type provides, and what do we mean by responsibility for care across the continuum. So we need to be able to recognize how that definition responds to the scope of care provided by each covered entity type.
Thank you. I appreciate that. I think it sounds like you and Dr. DeGiorgio are particularly focused on the notion that the right patients need to get this benefit. And I'd like to explore more. I don't have time now, but how complicated it would be to really get that benefit to follow the patient. I think that's obviously, in theory, the way they would work best. But if we don't define some of this stuff that's out there we know needs to be defined, we're not doing our job. And I look forward to work with everybody on this committee to get it right. And I yield back.
I now recognize Mr. Crenshaw for 5 minutes of questions.
Thank you to the chair and ranking member. Thanks to the witnesses for being here. Anytime we create a government program, we have to ensure they're living up to the intent of the law, and the 340B program was created to help underserved communities. And now there's a debate whether it was created to help the provider or whether it was created to help the patient. In Texas, we focused on the safety net hospital system, and I'm happy that many of our hospitals are going above and beyond providing charity care. With that in mind, we also need to ensure the principles are applied to the 340B program. So I just want to get some facts straight and some understanding of maybe the divisions in how we see this program. It's ultimately designed to help patients. We agree on that, but we see conversations about ensuring the benefits of the 340B program, the discounts, are reaching the patient. To that end, there's also been some controversy about whether we should have a patient ID so that we can match the savings with the patient. To Mr. Perry and Dr. DeGiorgio, maybe you could each comment from your perspectives on why a patient ID or a new definition of patient is either helpful or not helpful for programs' integrity and for patients. We'll start with Mr. Perry.
I can't really speak to patient ID, but I can tell you how we do it. We are very, very focused on compliance. We have to make sure that we are only being able to capture 340B savings on prescriptions that are for patients that are our patients. And the stakes are simply too great for us if we don't. If we start capturing a lot of patients that don't meet that qualification that has been laid out by HRSA and in the statute, we are at risk for paying back a tremendous amount of money, and that would be absolutely devastating to us. We have a lot at stake to do it right, and all the people I know that are in this program feel the same way.
I think the question about a patient ID is more of a concept of being able to capture each individual patient that is then in a transparent way that could be audited, or is, what? And my question would be, what kind of administrative burden does does that entail, or do you already do it anyway?
Well, we track every one of our patients anyway, but I don't know how an ID system, I don't know how that would work.
Yeah. Dr. Giorgio?
Yeah, I think it's important to know, where these patients get their care. We see it all the time where a patient may be seen once or twice at one institution, but they get the majority of care at our institution, and they're not even offered a follow-up at that other institution. And I think it's some sort of way of tracking to see if that institution is then trying to get 340B benefits for that patient, even though they're getting a majority of care with us, I think would certainly be helpful.
And how important are metrics like disproportionate share hospital percentage, the amount of payments given to hospitals for uncompensated care? How does that factor in?
The DISH metric I like because it's really tough to game that metric, right? So it's based on total inpatient days. I think that's a metric that's very difficult to game. Metrics like uncompensated care and charity care, there's a little bit of room for creative accounting there, especially when you consider uncompensated care. That includes bad debt. So just because an insurance company doesn't approve the bill doesn't mean that the hospitals is providing charity care for that. That just means that they didn't get paid. And then because hospital prices, there's not a lot of transparency in what prices mean. Just because a hospital says that an MRI costs $18,000 doesn't mean the MRI is actually $18,000 when you can get it down the street at an imaging center for $600. So there's a lot of creative accounting that can go into those sort of metrics.
Yeah, part of that creative accounting is the duplicate discounts. I think everybody agrees would be a problem, and some states don't have a means to report whether those duplicate discounts are happening. What are some solutions to that? Would greater transparency around duplicate discounts be beneficial? We'll open to that to the same, if anyone.
Yeah, certainly. I mean, right now there's states that don't even have any reporting mechanism to see if a drug was a 340B and an MDRP purchase.
And many of the proposals that have been discussed include an independent clearinghouse for all claims that would help identify those duplicate discounts.
Okay. Any other things to add?
Again, we work very hard to make sure that we don't have duplicate discounts because, again, we don't want to have to repay anything. And so that's something that we use our computer systems to make sure we track it well.
Okay.
I think it's telling that two very large states, New York and California, made it a point to carve out 340B out of their Medicaid managed care systems because they're so concerned about that discount and the money that they were losing by not capitalizing on the MDRP and instead foregoing it in favor of the CEs.
Mm-hmm. Okay. The public has no idea what you just said.
That goes for a lot of things.
It's complicated, and I appreciate you being here to talk about this complex and important subject. Thank you.
Thank the gentleman for yielding back. Now recognize Mr. Allen of Georgia for his 5 minutes of questioning.
Thank you, Mr. Chairman. Got it. Okay. Thank you, Mr. Chairman, for allowing me to wave on. I represent the 12th Congressional District of Georgia, and that includes a majority of rural counties outside of Augusta, Georgia. And ensuring that patients in those counties have access to care is very important to me. It is critical that this program be utilized to help underserved patients, and that's why we're talking about it today, especially those in rural areas and no one misuses the program. Ms. Veer is President and CEO of a community health center that serves as the primary care medical home for approximately 26,000 patients, and I believe you've done this for over 20 years. How can we ensure that the money within the 340B program supports rural hospitals and their patients like the ones in my district?
Thank you for the question, Congressman. And we've outlined several things about transparency and accountability. And I think we're in agreement about the need for transparency and accountability to achieve the purpose that you just stated. I think the biggest question is how. How do we, how and what are the parameters that we are going to suggest that we should charge HRSA with coming up with the reporting authority? And it's different. For example, I mentioned patient profile. The uninsured number doesn't really reflect the vulnerable populations that we serve. So that can't be the only measure. It has to be more of a comprehensive measure. You've mentioned the dish percentage and charitable care. And charitable care doesn't necessarily always reflect everything. So I think we're in agreement that there has to be a required reporting of use of savings and patient population served. The biggest question is how do we get to the details on it?
Right. Well, the agencies tend to overregulate the issue, and then we get all bogged down, and it becomes a mess. The 340B priced drugs are vital to treat patients, as we know, with chronic illnesses like diabetes, heart disease, and asthma. How does access through the 340B program support your health center's ability to manage patients' chronic conditions?
That's a wonderful question. One of the things that happens behind the scenes at a community health center is we have a department called Quality and Population Health. And it's 9 individuals that work diligently to make sure that patients that are already engaged in care are getting all of the preventive screens they need. They're coming back for their checkups when they're supposed to. They're filling their medications. We even get a roster of which of our patients are going to the emergency department instead of coming to their medical home, and we're following up with those patients. So that's a real investment in managing, and they're also helping with the social determinants of health. So do they have food insecurity? You know, do they have housing insecurity? So that's a behind-the-scenes operation that has no other source of compensation.
Well, in the district, the rural health centers, and even in the city of Augusta, the health centers are saying, okay, you're my patient, and so, please see me about any of your needs, and they monitor their meds and other things. And it is difficult. It's hard to do. Mr. Perry, as President and CEO of a rural high DSH hospital that also serves veterans, I'd like to give you the opportunity to answer the questions I asked Mrs. Veer.
Okay, so which one do you want me to start with?
Well, exactly, number one, how does access through the 340B program support the health center's ability to manage patients' chronic conditions?
Okay, so we have a very sophisticated electronic medical record system that 340B underpins the expenses of that. We are able to put all of our patients into different registries, so we understand which ones have chronic conditions. We're able to track them. We can understand if patients that are constantly using the ED inappropriately. We bring additional resources to those people, and we have a number of programs that the insurance companies will not pay for. Nobody will pay for it, but they reduce readmissions to hospital, and they enable us to take care of chronic conditions. The last thing is that a number of our clinics, like our endocrinology clinic with diabetes is a great example. We see a very large number of patients. We're the only endocrinology practice in the region, and we make sure that all of those patients who have diabetes have an opportunity to get their medication.
Right, good. Dr. Smith, real quickly, do you require discounts to be shared with patients at pharmacies you contract with through the 340B program?
I'm not a hospital administrator.
Right.
I'm just a policy analyst, so
Okay.
I couldn't answer that question.
All right, well, great. Well, I'm out of time. I yield back, but if any of you can answer that question, that'd be great for the record. Thank you very much.
Gentleman yields back. Now recognize Dr. Bouchon of Indiana for his 5 minutes of questioning.
Thank you, Mr. Chairman, and thank you all to all the witnesses. I think it's pretty clear all of us support the 340B program. It's critical. All my rural hospitals have to have the program. And the goals of expanding access to care and taking care of patients, I don't think that's in question at all from anybody. And I think nearly all of us agree that the status quo is not acceptable, because court cases have created some uncertainty for the future of the program. It is the responsibility of Congress to act to create clear definitions and guidelines for the program, in my view. And indeed, we're seeing that HRSA, the agency that oversees 340B, just doesn't have the authority to do so. Most of us recognize that 340B was created in the context of reducing drug prices for patients and expanding access. and that was Congress's original intent and how it ought to be working today. It's unfortunate that the nation's healthcare system has transformed dramatically over the last 3 decades, and the 340B program, in my view, hasn't kept up. As has been noted, I have legislation that seeks to rectify some of the problems at hand to ensure the long-term viability of the program, protecting it from potential court challenges and stabilizing it for future generations of Americans. H.R. 8574, the 340B Access Act, provides definitions for key terms that were missing in the initial statute, incorporates transparency requirements that will allow us to better understand how the program is or is not working, and states clearly the ways in which the program revenues must be used to benefit patients. So it's true that much of the policy disagreement that has occurred over 340B is due to a lack of clarity in the statute. That has led to disagreements, as was pointed out, between stakeholders about things like what it means to be a 340B patient and what it means for a hospital to use the money to benefit patients. Is there a risk that a court might strike down the program due to the lack of clarity in the statute? I don't know. Or at least interpret the vague statute in a way that Congress did not intend through the courts. Ms. Veer, because you're a grantee in the program, right? Mm-hmm. Based on that, you have reporting requirements through the federal government for some of the things you do, not through the 340B program, but from other parts of the programs that make you a grantee, which includes 340B related issues. Is that true or not true?
That is very true, and there's an intersection between the 340B requirements and Section 330, which is what we're funded and authorized under as a community health center. So, for example, our sliding fee scale. We are all required. Every health center that's an FQHC or a community health center grantee is required to have a sliding fee scale for everyone below 200% of poverty, and it must apply to every service you provide. Pharmacy is a required service, so there's an intersection there that says we must have a sliding fee scale for pharmacy.
Right. You find these reporting requirements onerous and not doable?
No. But of course, I've been doing them for a long time. They've become pretty much second.
But this is part of what you do, right?
It's
You're a grantee and you get 340B, but because of other programs, you have the responsibility to report on the 340B program.
Absolutely.
And that's doable and not onerous, in your words.
The responsibilities are not onerous, given the benefit it brings to our patients.
Great. Mr. Perry, you're a DISH hospital?
Yes.
So you would qualify the program under DISH, right?
Correct, yes.
What reporting requirements do you have for 340B under DISH?
So we report...
Just specifically for that, I know all the other things that you might say, but do you have any reporting requirements specifically related to the utilization of the revenue from 340B program for your facility?
We have a requirement from our board and from our mission as an organization to be very, very public with what and how we use the program. So we report that information. I'd be happy to share with you our report.
Right, but you don't report it to HRSA or anybody, right?
We only report to HRSA when they come audit.
Right, I understand.
and they do a very thorough job of auditing.
So the answer is no, essentially. And so that's a critical part of this is transparency that includes DISH hospitals. What year did you become a 340B grant hospital? Do you know?
I think it was in 2006, but I'm not positive. It was before my time at Genesis.
Yeah, it was around, let me see. I wrote it down. I actually looked. With your discretion, Mr. Chairman, October 2015.
That's incorrect.
Because that's what it says.
That's incorrect.
On HRSA's website.
That's incorrect.
Okay, fair enough. But what year did you say it was?
2006, I believe.
Okay, fair enough. Well, you need to let HRSA know that their website is inaccurate, that it's saying that you were approved in 2015 and became part of the program in 2015. I yield back.
Yeah, that's not correct.
Gentleman yields back and now recognize Mr. Joyce of Pennsylvania for his 5 minutes of questioning.
Thank you for allowing me to wave on today to this important hearing, Chairman Griffith, and thanks to our panel for appearing today to discuss what is a very complex and important issue to many health systems and providers within my home state of Pennsylvania. The 340B drug pricing program was created in 1992 and aimed at enabling certain healthcare providers, known as covered entities, to stretch scarce federal resources to reach more eligible patients or provide more comprehensive services. Between 2000 and 2020, the number of covered sites participating in the program grew from over 8,000 to 50,000. During the same period, discounted purchases in the program grew from $4 billion to over $38 billion today. The original intent and goals of this program are critically important to protect patient access to care, but we cannot turn away from the staggering growth of this program and the impact that this is having on other segments of healthcare delivery system. I want to also be clear that we must ensure that any reform in this space cannot come at the expense of patient access to medications. Dr. DeGiorgio, the 340B program has grown massively since its enactment, what I just elicited, growing almost 130% in the last 5 years alone, and is second only to Medicare Part D. This growth has created misaligned incentives across the entire healthcare system, leading to further consolidation that drives up prices for every patient. In your opinion, would requiring covered entities to spend 340B savings directly on patients curb these abuses?
I think it would have some effect. I think there's going to be plenty of room for creative accounting around that. Again, as I said earlier, hospital prices are not very transparent to begin with, and so simply requiring hospitals to say that, again, if an inpatient MRI is $18,000 when it's really $600 down the street, does that really mean that the hospital is spending this money on inpatient services? There was a good article by Seya Nikpe in 2020 showing that 340B hospitals, in fact, reduced their charity care offerings when they joined the 340B program. And they have charity care offerings, but they offset that by reducing services in other areas. So I think there's a lot of ways that hospitals will get around that reporting requirement. I
don't like the concept of any creative charges or financing. I think transparency is important to all of us. One of the things I think is really, one of the things that's really driving the growth of the program and a lot of conflict over the future of the program amongst the stakeholders is the lack of a definition of a 340B patient. How would you recommend Congress define what a 340B patient is, Dr. DeGiorgio?
I think that they should have established ongoing care with that entity. And that can be something as simple as, a cancer patient that sees their oncologist and has an established oncology plan and continues to have regular check-ins via telehealth, via phone call, et cetera. But as long as they have an established ongoing care plan with that facility, they can be a patient and not just
I think that certainly could be one of the requirements for identification of a 340B patient. Mr. Perry, there's currently no requirement that 340B covered entities pass savings along to patients. Right now, most patients receive 0% discount on prescription medication purchased under a 340B program, while according to HRSA, hospitals receive discounts of up to 50%. Why are discounts not passed on to the underserved and the vulnerable patients that this program was intended to serve?
Respectfully, Congressman, I disagree with your proposition that hospitals do not pass along those savings. As I described in my earlier description, we provide a discount program for patients who cannot afford their medications. It is only if you're under 400% of the poverty limit, any prescription that you fill from one of our covered entities costs you only $5. And we spend $3.5 million a year making sure that our patients get their medications. That's a huge part of our program. So I just believe
that's
that's
for all
incorrect.
patients or just for 340B defined patients?
It's for all. It's for any patient who needs their medication.
But if a patient has a subsequent insurance and the insurance company is building their additional costs that are recouped by the hospital, where do those funds, where do those resources?
I'm sorry, could you repeat your question? Sorry.
Yes, if a patient has an other insurance that is not an underserved patient, but a 340B program is utilized, Where are those resources? Because they are not refunded to the patient.
Right, so that is where the funding for 340B actually it comes through. It's through either insurance, patients who have insurance, like commercial insurance or Medicare. And if we were a 340B hospital, or if we weren't a 340B hospital, those payers would be paying the exact same amount. So it basically gives covered entities the ability to use those savings to be able to reinvest back into our entire care system.
My time has expired. I will submit the rest of my questions for further review. Thank you, Mr. Chairman, and I yield back.
I thank the gentleman and now recognize Ms. Harshbarger of Tennessee for her 5 minutes of questioning.
Thank you, Mr. Chairman. Thank you all for being here today. I want to start with Dr. DeGiorgio. My understanding is that much of the growth in hospital spending is due to consolidation that's driven in part by the 340B program. Because taxpayers pick up the bill for a big share of healthcare costs, doesn't this mean that the currently constructed 340B program contributes to increasing federal healthcare costs, sir?
Absolutely. I keep bringing up the MRI price, and this is a true story of a family member of mine who asked for advice on their MRI brain. It was clearly indicated, and the hospital, without insurance coverage, would have charged them $18,000. With insurance coverage, the copay was $1,800. So we Googled it together, and down the street there was an independent imaging center that could get the same MRI done for $600.
Yeah, absolutely. You can shop your health care out. I know.
Absolutely.
And they don't like it when you were transparent with those prices, sir, and it happens in my rural area as well. If the 340B program were reformed to reduce incentives for consolidation, could federal health care costs be reduced?
Without question.
Without question, exactly. Another question for you, sir. The Kaiser Family Foundation reported that the total value of tax exemptions for nonprofit hospitals was nearly $28 billion in 2020, nearly double the amount in free or discounted services provided by such hospitals during the same year. These savings from tax exemption are in addition to the profit that 340B hospitals collect from participation in the program, which analysts estimated was $44 billion in 2022. Do you think the federal government should establish requirements for tax-exempt charitable hospitals participating in 340B to meet their obligation to serve larger shares of vulnerable patients and then invest in increased access to affordable medicines and healthcare services for these communities?
Absolutely. A lot of the things that we're talking about that these hospitals claim they use their 340B funds are actually why they have tax exemptions. So they're supposed to be doing these community outreach programs regardless, because that's why they get this very large subsidy by not being required to pay taxes. So if they need an additional subsidy on top of their tax exempt status, we should be having that conversation, not saying how we're going to game a pharmacy benefit program because that they simply can't operate efficiently enough to run in the black.
Well, that's not good. Ms. Veer, the National Association of Community Health Centers recently endorsed legislation that I introduced with Reps Bouchon and Carter that would reform the 340B program, make it more transparent. This legislation will allow small rural hospitals like critical access hospitals and sole community hospitals to have an unlimited number of contract pharmacies to serve their patients. In addition, many rural patients would qualify for a lower cost sharing on their medicines. Do you think these changes will help these rural hospitals and their patients?
Thank you for the question. And yes, absolutely. And I appreciate any effort to help our rural hospitals and our critical access hospitals remain in that role. We're seeing so many of them that are either becoming part of a larger system, and I think it's critical for them to have that support.
Absolutely. I mean, you see a lot of consolidation, vertical integration, and that's not good.
No.
I've been an independent pharmacy
Not
owner
completely.
for 38 years, so I understand how this works.
Yes.
Let me ask you a question, too. You said something in your opening statement a few minutes ago about manufacturers imposing arbitrary conditions and restrictions on the 340B. Can you elaborate a little bit on that?
Certainly, as I think everyone, certainly at the table and mostly in the audience, know that it's been about 3.5 years since the manufacturers began restricting the use of 340B at contract pharmacies. That has obviously been expanded to include almost, I don't even have the number in front of me, but for example, we have a very robust in-house pharmacy, but both of our in-house pharmacies are located in Greenwood, which is only a piece of our service area. So we've got to reach people across 3,708 square miles.
Yeah.
And these are people that live in rural communities. They can't travel far from home all the time.
Absolutely.
And so, yes, those restrictions are limiting our ability to serve the patient. In addition to that, the conditions have to do with data submission. So we've agreed to submit data in order to participate with one contract pharmacy or another. But unfortunately, that's an incredible
You're right
administrative.
there. The pharmacy's inside the health center. I mean, I have them in my district, and I go visit them on a regular basis.
Yeah.
So we want them to thrive.
Yes.
Oh, I've got 15 seconds left. Dr. DeGiorgio, can you address concerns that the 340B program's eligibility criteria may be too broad, allowing large hospitals and healthcare systems to participate despite serving relatively affluent patient populations, potentially diverting resources away from truly underserved communities?
Right,
And I'll
yeah.
let you answer because I've got to yield back.
Yeah, 11.75% is a pretty low threshold. And then when you neglect to include child sites that could be in wealthy communities that don't serve a single low-income patient, yeah, there's a lot of room to improve the eligibility standards.
Yeah, she'll do those for the record. We appreciate you. And now recognize Mr. Bill Arrakis of Florida for 5 minutes of questioning.
Mr. Chairman, I appreciate it, and thank the ranking member as well for having this hearing. While there are many ideas and concerns that have been laid out today, particularly about the explosion of growth in the program, I think we all want to ensure there's a robust and sustainable system available so those who are in most need can get access to life-saving drugs. And I do believe reforms may be necessary to do just that. That said, Congress always intended for the 340B program to serve uninsured patients and facilities that provide higher rates of uncompensated care. However, due to the Biden administration's departure from decades of established policy from both parties, which previously allowed providers in my state of Florida to count uncompensated care pools, utilizing our state's Medicaid 1115 waivers towards the Medicaid fraction of the DISH adjustments, I'm concerned we are no longer on a level playing field for those states. Uncompensated care pools are a unique way to ensure funding for care of the uninsured, and states such as Florida and Texas utilize this effectively through their 1115 waiver. Unfortunately, CMS's unprecedented interpretation is now affecting 340B eligibility for many hospitals that care for these underserved patients, leaving them at a greater disadvantage. So, Dr. DeGiorgio, wouldn't you agree that we should be finding ways to incentivize providers to continue uncompensated care to those that need it?
Absolutely. And again, I think that there's plenty of discussion to go into reforming how our public safety net payer system goes. I don't think that we need to necessarily game the 340B system to pay for uncompensated care, and there's a ton of conversation that can go into how to better fund the safety net system. Medicaid is historically provides very low reimbursement levels, and there's a lot of discussion we can have over how to improve the reimbursement for Medicaid and uncompensated care.
Good, thank you. Mr. Perry, would you like to comment on the need to ensure 340B supporting hospitals that provide more uncompensated care for these uninsured and low-income communities?
So yeah, the way that we do it, I can describe how we function, which is we take care of everybody. There is nobody for us to send a patient to that doesn't have good insurance. We take care of everybody. That is our mission. We serve a 6-county service area that has very high poverty rates. That has 33% of the people who live in that 6-county service area have Medicaid for their insurance. So the whole program is designed to give us the ability to care for everybody, and we do that, and we do that very, very well. I'm not sure if I answered your question.
Oh, go ahead. You can elaborate more. I have time here.
Okay, so, I know there have been several different things here. So, for instance, our tax exemption requires us to provide a certain amount of care to indigent people. The 340B program, which we do, the 340B program enables us to do that at a much greater scale. We are a very, very efficient hospital, and I can show you national data through comparison databases that shows that we are extraordinarily efficient. We still lose huge amounts of money taking care of both Medicare and Medicaid patients. And so the ability for the program, the ability to make sure that we can use it in all sorts of different ways, it gives us that ability to make sure that we're caring for everybody. And I'm accountable to a community board who makes sure that's we live our mission every day.
Okay, thank you very much. I yield back, Mr. Chairman.
Gentleman yields back, and now recognize Mr. Carter of Georgia for his 5 minutes of questioning.
Thank you, Mr. Chairman, and thank all of you for being here. Mr. Perry, are you opposed to transparency in the 340B program?
No, sir, I am not. We
Then
are.
have you read our bill, the bill that Dr. Bouchon and Dr. Harshbarger and I, have you read that? Is there something in there that you're opposed to?
So you're talking about any component of the bill?
Any component of the bill, but particularly
Sure.
transparency.
Sure.
Particularly trying to show us exactly where this is going, how it's being spent.
Yeah, so I would be happy to share with you our 340B impact study that we do every single year.
No, that's
and
not
that is-
what I ask you. I
Okay.
ask you, are you opposed to transparency?
No, I'm certainly not opposed to transparency. I am opposed to transparency that cherry picks the type of information that completely distorts the way 340B is designed to do. So if you only provide information
So you were
about,
part
can you-
of
may I-
the,
can
you
I
were part of
finish,
the
please?
program that this program, that 340B was established in?
I'm sorry, I was trying to finish. So if you only report on, let's say, charity care, and then you are, and especially in a state like Ohio that expanded Medicaid, okay, so there are very few people that have no insurance and have no resources because they're in Medicaid.
Mr. Perry, with all due respect, sir, I'm a pharmacist. I had 3 retail drugstores, and I participated in this program. So
Right.
you don't need to coach me about it. I understand it. I
just trying to
lived it.
understand what
I
you're
understand.
what you're asking.
But what I'm asking you is
Yeah.
about transparency. And I'm asking you, why are you opposed to it?
I told you I'm not opposed to transparency.
But-
I am,
but
I
now
am
you're going
opposed to I am opposed to transparency if you are collecting data in a way that is going to be used against organizations that provide a comprehensive set of services to patients because you're only collecting a very small piece of it. So
Okay, well, thank you
that's
for
what it
your
is.
answer. You know, look, when this program was established, it was established to help low-income and vulnerable patients access
Which we do.
I'm sorry. Thank you for your answer.
Thank you.
Okay. When this program was intended to do was to give low-income and vulnerable patients access to affordable medicines, and what it has evolved into is something far beyond that. We've got now situations where hospitals, healthcare systems are buying practices up for no other reason but to get the pricing of 340B. I've seen it firsthand. You can't convince me that that's not happening, and that's what we're trying to resolve. We're trying to keep a program that is a beneficial program that is going to help low-income and vulnerable people. We're trying to keep it going, and that's the intent here. That's the intent of our bill, is to have transparency in here. The Cleveland Clinic Health System, which is structured as a nonprofit health system, generated approximately $136 million in revenue from the 340B program in 2020. Yet the Wall Street Journal analysis, in a Wall Street Journal analysis, the charity care the main hospital wrote off represented less than 2%. Less than 2%. That, you know, Dr. Giorio, is it reasonable to think that some business decisions are not being made in the best interest of patients and instead are designed to maximize 340B profits?
Absolutely, and we see this on the front lines every day. I've mentioned hospitals turfing patients to us when they show up in their ER. Then they do what we in healthcare call a wallet biopsy, and if they don't pass that, they send them to our community hospital instead of keeping them, taking care of them there. So there's no question that goes on.
How can we ensure that most of the funds in the program are reaching underserved patients that this program is supposed to benefit? How can we do that?
Yeah, I think simple transparency, as you brought up. Yeah, just showing who purchased the drug, who reimbursed the drug, which patient it went to, and then how much revenue was made off of that resale.
And have you looked at our legislation that we've introduced?
I have, yes.
And what do you think?
Yeah, I think the transparency is great. I think including outpatient child sites for the dish calculation is a great step, including possibly adjusting the overall dish calculation. I like having it targeted at a percentile of dish hospitals rather than an arbitrary cutoff. I think there's a lot of great things. It's a great start, and thank
Ms.
you.
Veer, I've worked with a lot of FQHCs, and you know, I'm trying to keep this program going primarily for them, because that's what it was intended for those types of facilities. And have you read the legislation?
I
you
have.
seen it? And do you
Yes, sir.
think that this would help the FQHCs?
I think this is an exceptional starting place, and it was critically needed. I think
Right.
there's still some.
I mean, they've even come to me and they want to start a 340C program. They want to just start over.
Yeah, and I've heard that, and Congressman, I would respectfully say dealing with a single entity-centric solution doesn't work, because this program needs to work as a whole across the healthcare delivery system. You can't just fix it for health centers.
Right. Right, I understand, and I've told them that, and I've agreed that that's not the way for us to go. But I still feel like that our legislation that we've introduced is a good start, as you say, and would help sustain this program that is much, much needed. Thank you, Mr. Chairman, for allowing me to wave on, and thank all of you again for being here.
Seeing there are no further members wishing to ask questions, I would like to thank our witnesses again for being here today. At this moment, I will recognize Ms. Castor for a motion.
Thank you, Mr. Chairman. Thanks again to our witnesses for a great discussion today. And I want to thank the professional staff and offer for the record HRSA detail that confirms that Genesis Healthcare System, Zanesville, Ohio, entered the program in 2007, just to clarify. Apparently, there is another Genesis Healthcare out there that may have caused some confusion.
Seeing no objection, that'll be added to the list. At this time, I ask unanimous consent to insert in the record the documents included on the staff hearing documents list. Without objection, that will be the order. Pursuant to committee rules, I remind members that they have 10 business days to submit additional questions for the record, and I ask the witnesses to submit their responses within 10 business days upon receipt of the additional questions. Without objection, subcommittee is adjourned.